Hello, everyone. Welcome to this evening's webinar. I'm so happy to have you all here today and to welcome our guest speaker, Stuart Wakefield. So this afternoon or this evening, we'll be having our webinar discussion on lower extremity assessments. My name is Savita Baja, and I am the Vice President at the OKA this year. And a little bit about Stuart. Stuart, with over 10 years of experience as a personal trainer and registered kinesiologist, uses evidence-based barefoot training techniques to improve movement longevity throughout sensory stimulation, fascial health, and foot stability. Stuart graduated from the University of Guelph with a Bachelor's of Applied Science in Kinesiology and is the Director of Education in Canada for the EBFA Global. He offers EBFA Global's in-depth lineup of continuing education seminars that include the Barefoot Training Specialist Certification, the Neurosensory Specialist Certification, and the Pelvic Balance Certification. Stuart resides in Windsor, Ontario, and with his wife and his 2 children. So I'd like to take the time today to welcome Stuart. And throughout the presentation today, we want to both encourage you to all ask any questions that you may have and just place it in the Q&A box at the bottom of your screen. We'll try to answer any questions that are relevant to the topic at hand right as we're going through, and otherwise we'll answer any other questions at the end of the presentation as well. There's plenty of time, so make sure you do ask any questions. And without any further ado, I'll hand it over to you, Stuart, and you can get started.
All right. Well, thank you so much for that introduction. And thank you, of course, to the OKA for inviting me to do this. As was mentioned, the term movement longevity, that's something that I'm very, very passionate about. I'm sure many of you are as well. I truly believe the foot is the linchpin to movement longevity. Of course, we're bipedal beings. Our feet are our first point of contact. And the sensory information we get, or maybe we don't get from the ground, along with how our joints respond to the ground, really dictates our level of efficiency. Of course, our topic today can be viewed as an introduction to some of those EBFA Global seminars that I teach. Specifically today, we'll be discussing a little bit of an introduction to our barefoot training series of workshops. So, of course, if you'd like to expand your knowledge on this information that we're going to cover today, I'd highly recommend you look into those seminars. As you can see on the slide here, we're going to specifically look at assessing our foundation. So just a very quick and simple functional foot analysis that you can perform on your patients if that's not a tool that's already in your toolbox. So as we jump in, we'll just briefly look at our learning objectives for today. So first off, we're going to start by talking about the 3 main purposes of the human foot, and that really gives us a good foundation to build the rest of this brief seminar off of. Then we're going to jump into some biomechanics. Hopefully we'll all get on the same page and understand some of these important movements that need to occur through the foot, specifically during our gait cycle. Then we're going to look at 3 very simple closed chain assessments that can be done for the foot. And then lastly, we'll wrap up with just some general corrective exercise techniques. We're not going to have time enough to really dive into the nitty gritty with regards to correctives, but I do want to give you some practical things to look at and maybe apply as soon as tomorrow with your patients that you're seeing. So let's go ahead and dive right in here again, starting with the 3 main purposes of the human foot. Okay, now when we talk about the 3 main purposes of the human foot, we're really looking at what our foot is responsible for during the gait cycle. So we've kind of broken down the gait cycle a little bit. We're looking again at these 3 main functions. And of course, that's going to start with shock absorption. I love the quote that's on the slide from Dr. Emily Splichal. She's the founder and CEO of EBFA Global. Our foot must be able to adapt to the ground. Our foot needs to be a mobile adapter. Of course, while it's somewhat obvious, our foot, or more specifically our calcaneus, of course, being our first point of contact with the ground, okay? When our calcaneus, when our heel strikes the ground, our subtalar joint should be positioned in an inverted position, okay? When you think of inversion, think of a position that's locked, stable, and very rigid. That's how we want to strike the ground. We need that stability when our foot impacts the ground, okay? The impact we experience at foot contact, though, is going to create what we would call a medial tilt of the heel, of the calcaneus, or just relative subtalar eversion. And we're going to dive into the biomechanics. So if you're not super familiar with inversion versus eversion, we'll break all that down a little bit later for you. Okay, so ultimately here, what we're seeing is this adaptation from a locked position to a more unstable position, allowing for that shock absorption. Essentially, you can think of shocks on a vehicle, for example, that have become, very rusted or rigid because there's no adaptation. Okay, more of that shock, more of that impact force is going to get transferred to the frame of the vehicle. And of course, that's going to increase the amount of wear and tear over time. So again, we can often refer to the foot as this structure that needs to adapt to the ground. We need it to be a mobile adapter, one that is both flexible, but also able to stiffen and become rigid when necessary. So that's number one. We need to be able to absorb shock. We need to be able to adapt to the ground. Moving on here, number two, when we're relating this to the gait cycle, you can think about mid stance. So this is our single leg balance position. You could certainly argue that this is the most critical part of the gait cycle. We often refer to this as the peak point of stability. We're on one leg, we need foot stability, we need pelvis stability. And of course, we want to not only focus on the foot, but appreciate the role of the pelvis here and the importance of course, core, gluteus medius activation that's required at this point during the gait cycle. We must also acknowledge the importance of balance here. Of course, that's required during this single leg position at mid stance, okay? As it says on the slide there, a quote from a study, walking speed or lack thereof, often referred to as the sixth vital sign, has been shown to predict many different outcomes, including cognitive decline, falls, and all-cause mortality. So while balance is achieved through a multi-system integration, of course, proprioceptive, vestibular, visual system, okay, we can reference the importance of foot stabilization achieved through muscles in the lower leg and foot, such as the soleus, the post-tib, flexor digitorum longus, flexor hallucis longus, and of course, our often neglected intrinsic foot muscles that we need to train like every other tissue in our body. So again, what we're looking at here is just the importance of training these systems together in order to maintain balance, because essentially what this study is telling us is that if our walking speed slows, okay, we are going to, our mortality is going to decrease, right? Our longevity is going to decrease, okay? So in order to maintain that, if we can train our proprioceptive system, our vestibular system, and our visual system together, we'll be able to, again, maintain better walking speed and therefore maintain our longevity as human beings. Okay, moving down to our third one here, propulsion. Okay, this is honestly probably one of the most fascinating aspects of the gait cycle. Okay, as it says on the slide there, often referred to as the push-off phase of gait. James Earls, in his book, Understanding the Human Foot, refers to this as toe-off instead. And of course, again, referencing that quote there, pushing off with deliberate muscular contraction is not necessarily our default action. It is just one option that's available to us in response to movement variables, such as walking faster or uphill. So what does this mean essentially? Propulsion doesn't have to equal active hip extension or active ankle plantar flexion. It could potentially, as it said, if we're walking up a hill, if we're going from 0 miles an hour to whatever our walking speed is, essentially as we're speeding up. Okay. So this is often referred to as the catapult effect. Okay. The human body has this incredible ability to double the ground reaction forces we take in at heel strike. And that essentially demonstrates this incredible elastic potential that we have in our tissues, specifically our fascia. And of course, this elasticity is very much the foundation to efficient movement.
We have a question here before we continue.
Okay. Sure.
Have these studies considered orthotics, which may contribute to the stability and offer impact absorption?
That's a great question. With regards to studies and impact absorption, I think it really depends on the type of foot posture they're studying. So if you're looking at someone who's really, really overpronated and you put them in an orthotic, you are definitely going to see a better shock absorption result. Whereas on the flip side, maybe someone with a more neutral or stable foot in any type of an orthotic or an arch support, again, especially with something like running, you don't want to block that absorption. So two sides of the coin there. I've seen studies, again, from both perspectives. Again, if you're overpronating and you have that flexible flat foot, you're definitely going to benefit because it's going to help you with that deceleration, which we'll talk about a little bit later on. And then again, from the flip side, again, if you're oversupinated, you have a really, really high arch, you don't want to block that impact absorption. So you could definitely see that from both sides, but great question for sure. Continuing on with regards to propulsion, with regards to the catapult effect, I often refer to this just as a bow and arrow analogy with my patients, right? So you can think about your foot as it strikes the ground, it goes from heel contact through mid stance into that toe off or propulsive phase of gait. The longer that foot's on the ground, the longer or the further that bow is getting stretched. And then obviously your foot leaves the ground, that arrow gets released and it's going to fly farther. Right. So we want to maintain good walking speed, good length in our stride, and obviously have ideal joint movement in order to access this propulsive or efficient propulsive phase of gait. From a biomechanical perspective, our ability to take advantage of this elasticity is very, very highly dependent on our foot being able to achieve a rigid lever position. Again, we'll get into the biomechanics here shortly. But again, as we go through our gait cycle, our foot needs to maintain a neutral position. So you can think when you're in that mid stance position, you're in single leg balance. We want to have a very, very neutral foot, of course, until we start to toe off or push off the ground. Okay. That's where our subtalar joint must start to invert. Okay, you can think of inversion again as that locked, stable, and rigid position. While there are many inverters of our foot, it's very important to note the importance of our posterior tibialis. That is the most powerful supinator of our foot. It's going to invert the subtalar joint, assist in plantar flexion of the ankle, and essentially just assist in controlling the amount of arch compression when our foot hits the ground. So you could talk about orthotics in terms of controlling a person's arch, or you could look at training that post tib. Okay. And then lastly, with regards to propulsion, we have to appreciate the importance of metatarsal splay at toe off. So if I bring up my little foot model here, again, you can see the metatarsals, see the toes. You can see there's a little piece of wire going through the met heads there. So that would be very similar to what's called our deep transverse metatarsal ligament. So if you take the palm of your hand and you cup it like this, and you feel the tissue between the bones there, it's very, very soft, very, very relaxed. And then take your fingers, open them up, splay them, stretch them out as far as you can. That tissue becomes very, very taut, very, very rigid. And that's what our foot should do as we're pushing off the ground. So that's going to apply tension to that deep transverse metatarsal ligament. That's going to allow for proper function, proper force distribution through the metatarsals. We want to avoid possibly being in footwear that's going to compress our metatarsals. And then you can appreciate the importance of that, especially if you're working with athletes who are maybe running long distance. To get optimal stability at push-off, our metatarsals must splay. And then while we're talking about the forefoot, we should probably acknowledge that it's the job of the toes to stay long, flat against the ground. I'm sure you've all seen in your patients different variances of claw toes, hammer toes. They can all be caused by several different reasons, but ultimately it's a sign of increased gripping or clawing the ground at push-off, and it's ultimately a sign of dysfunction. So when it comes to training our toes, we want to appreciate the importance of training the foot as it's meant to be used, specifically through our gait cycle, right? It's the most functional movement that all of us and all of our patients do on a daily basis. We need to be efficient when we walk as it relates to movement longevity and aging well. And training our toes to stay long, straight, flat on the ground is going to be training them essentially how they need to function during that toe off or propulsive phase of gait. So what we're going to do with those three phases of gait, or those three purposes of the human foot, we're going to look at assessing them a little bit later on, specifically our mid-stance position and then our propulsive position. Okay. So moving on, looking at, again, the foot as our foundation here. Okay, we're going to do just a relatively brief review of the biomechanics, focusing mainly on our rear foot. We'll look at the forefoot briefly. Again, just always remember this analogy that you can see on the screen here of this house falling over, right? Our foundation must be strong with regards to prevention and rehabilitation, especially with regards to foot and lower extremity injuries. So just a brief X-ray view here of the rear foot. Again, our main focus is going to be on the ankle joint. We're going to talk about the subtalar joint in a bit of detail as well. And then again, you can see just a different view here looking at the calcaneus. You can see more of the lateral column of the foot, the cuboid, the fifth metatarsal. Again, our main focus is rear foot. We're going to touch on the forefoot, specifically our first metaphalangeal joint, or essentially just our big toe joint right here. As mentioned, starting with our rear foot. So that's made up specifically of our ankle joint and our subtalar joint. Okay, oftentimes when I'm teaching a workshop live and in person, I'll open this up as a question, and I'll often get answers with regards to the movements of the ankle joint. You know, some people might say inversion or eversion, possibly through pronation or supination. Again, one of my goals with a seminar like this is just to clear up any confusion or misconception around the movements of the rear foot and how the ankle and the subtalar joint interact together. So hopefully we can clear some things up. Okay, if we review the three planes of motion, okay, we've got our sagittal plane, our frontal plane, and our transverse plane. Okay, we need to appreciate that the ankle joint moves through two of those planes of motion at the same time. Okay, so at the ankle joint, okay, we've got sagittal plane motion and we've got transverse plane motion. Okay, those are always coupled together. So again, they're happening at the same time, and we'll look at exactly what they are momentarily. Okay, the reason behind it being coupled like this, or the reason why it's moving through multiple planes of motion at the same time, has to do with what we would call the ankle joint axis. Okay, so if you were to just reach down right now and bisect your ankle joint, your medial malleolus sits more anterior and superior, and your lateral malleolus sits more inferior and posterior. Okay, and that's what's really creating this multiple plane movement at the ankle joint. And this is what it looks like. So this is how it's coupled. So whenever your ankle dorsiflexes, it is also going to abduct. Okay. Whenever your ankle plantar flexes, it is also going to adduct. Okay. And those are, again, always coupled together. So when we think about going through that gait cycle, our foot's in contact with the ground, we're going from that heel strike position to late mid stance. So our ankle is dorsiflexing, it is abducting as well. Now, again, the precise degrees of motion are obviously going to vary person to person. There's certainly ideals that we want to look for, especially with regards to dorsiflexion, but I just want you to appreciate that these are always coupled together. Okay, and of course, because we're relating this to walking, we want to appreciate how many degrees of ankle joint dorsiflexion that's required to walk essentially without compensation. Okay, so if we look at this little picture of a human walking here on the slide, the shaded portion of the person here, that represents late mid stance. Okay, and that is where the peak, that's where the most amount of dorsiflexion is required. And again, remember, this is passive dorsiflexion. Okay, so how many degrees of dorsiflexion do we need during late mid stance to walk without compensation? The answer is 5 degrees. Of course, you can make an argument that ideal would be 10, maybe 15, but the bare minimum that we need to walk without compensation is going to be 5 degrees of ankle joint dorsiflexion. What's interesting is if you assess people's ankles on a regular basis, you can probably appreciate this, but most people have about 0 degrees. And that is why so many of us walk with compensations during our gait cycle. Now, oftentimes those compensations don't cause us any pain, but what we're looking for is things that are going to prevent efficiency. So as we age, as we get older, as we move more, are these compensations going to lead to more dysfunction, maybe pain down the road? Okay, so some of those compensations that you can see, probably the biggest one is going to be an abducted gait. So how many people do you see on a daily basis who walk with their feet pointed outwards? A lot of people. More times than not, that is because of a limited ankle joint dorsiflexion. Okay, you'll see what's called a low gear push off. So as they go from that mid stance to late mid stance into that propulsive phase of gait, their inability to get over top of their big toe efficiently is going to result in a low gear push off. That essentially just means that they're not using that elastic capability, that elastic potential, and it's less efficient. So you could say it's a more muscular dominant gait cycle. The problem with that, muscles require energy, right? The more we walk and have to use muscles to power us through that gait cycle, the more energy we use, the more oxygen that's required, heart rate gets elevated, walking becomes very hard, and then we don't want to do it. Okay, so again, things to look for in our patients where we can possibly make changes to positively affect their efficiency. When we lack dorsiflexion, we can also see subtalar joint eversion, and that could result in pronation, and we'll expand on that shortly. You may also see something like an early heel lift. So have you ever seen someone when they're walking, they have a real bounce to their step? it looks like they're kind of almost more walking up and down versus forward. That often is a result of, again, a lack of dorsiflexion and that early heel lift. Okay, we're going to move on here to our subtalar joint. Okay, the subtalar joint is truly our foundation. Okay, when our foot contacts the ground at heel strike, this is the first joint to adapt to the ground. Okay, so we need to understand how to control, how to strengthen, how to prevent certain movements at this joint in order to make ourselves, our patients, as efficient as possible. So at our subtalar joint, we're looking at frontal plane movement this time. Okay, and what you see on the screen here, the two depictions of inversion, eversion, these are kind of the extremes, if you will. Okay, so when I talk about pushing off the ground in an inverted stance or an inverted position, I don't necessarily want to be this far inverted. Okay, when I talk about relative eversion or adapting to the ground at heel strike, I don't want to see this. Okay, this is just to help you appreciate the positions of the subtalar joint. And again, eversion being more of that medial tilt of the heel, inversion being more of that lateral tilt of the heel. Again, this is frontal plane motion. Most of us should have a 2-to-1 ratio. So if you're assessing someone in open chain and you're feeling that subtalar joint movement, there should be a 2-to-1 ratio. So there's going to be double the amount of inversion compared to eversion, approximately 22 degrees of inversion compared to 11 degrees of eversion. Okay, just while you're sitting in your chair at the moment with your feet flat on the ground, just take your arch, push it towards the ground, go through that everted position, and then go back to inversion. Just do that a couple of times. So go eversion, inversion, eversion, inversion. What I want you to feel as you continue to do that is how your tibia is rotating internally with eversion and externally with inversion. Okay, this really shows us that frontal plane movement drives our transverse plane, specifically when we're walking, running, jump landing. Our frontal plane subtalar joint movements dictate our transverse plane control. Okay, so let's say you're working with athletes, working on jump landing and trying to get them to control the tibial and femoral internal rotation. Look at their subtalar joint. Definitely something to consider. Okay, there are certain terms, as I've already alluded to, that we can associate or classify with regards to eversion and inversion. So when you see an inverted foot, or when you just think inversion, think how, a foot needs to become rigid. It needs to become stable as it's pushing off the ground. Oftentimes when we're pushing off the ground, we're releasing double, triple, sometimes 4 times our body weight, depending on the activity, right? So that tells us that our foot must be very, very stable as we're releasing all of that impact or all of that energy. Okay, and then on the flip side, we've got eversion, typically associated with hypermobility. It's an unstable position. Of course, we want to unlock when we hit the ground, right? So when I hit the ground in that stable inverted position, that adaptation is through relative subtalar joint eversion, and that's how I load the impact of the ground. I often like to refer to an inverted subtalar joint. Like if you're assessing someone and you see something as extreme as what we see on the left side of the screen, when that person walks, runs, jump lands, that's like a cinder block hitting concrete. There's no adaptation in that foot type. And our goal as therapists should be to allow or to help that foot become more of that mobile adapter to improve shock absorption, like we talked about earlier on. Okay, again, those are some classifications that you can apply to the subtalar joint. And then functionally, when you're thinking inversion, okay, if you're going to couple that with other joints, When our subtalar joint inverts, our ankle joint is going to plantar flex and our tibia is going to externally rotate. Okay, again, think push off and gait. It's a rigid foot. This is how we accelerate. Okay, functional eversion. Okay, think ankle joint dorsiflexion, think tibial internal rotation. So think about when our foot is striking the ground during walking, running, jump, landing, it has to unlock, it has to load the impact of the ground. We're decelerating through that adaptation. Okay, now if we take our ankle and our subtalar joint and couple them together, which is very, very important, we get to look at pronation and supination. So again, this is a question that I always ask when I'm teaching these seminars. How do you properly describe pronation and supination? We need to appreciate now, of course, we're not going to get into the midfoot today. We're focused, like I said, on the rear foot, but our rear foot can pronate and supinate, and our midfoot can pronate and supinate, and they're not the same thing. So we need just to appreciate the importance of the complexity of the foot and just how to properly describe these terms if we're speaking to other therapists, our patients, etc. So one of the most important things you can appreciate with regards to pronation and supination is that it is a triplanar motion. Okay, so we've got 3 planes of motion all at the same time, and it requires 2 joints. So we've got 3 planes of motion, 2 joints, all at the same time. And on the screen here, you'll see what it looks like. So when our subtalar joint everts, that is always, always coupled with dorsiflexion and abduction of the ankle, and that equals rear foot pronation. On the flip side, subtalar joint inversion, always, always coupled with ankle joint plantar flexion and adduction. That equals rear foot supination. I know it can be somewhat complicated if you haven't learned this information previously, or maybe it's just good review, but I highly recommend just memorizing that. And then it's helpful when you go to assess someone, you can appreciate the position of the subtalar joint. You can watch them walk. You can appreciate that, okay, their subtalar joint is everting during late mid stance when they're dorsiflexing and abducting. Therefore, they're pronating. Okay, pronation in and of itself, of course, is not a bad thing. Pronation, again, is how we adapt to the ground through that eversion, right? It's something, however, that we want to be able to control. And of course, the same goes for supination. We don't want to over supinate as well. Okay, hopefully that was helpful and fairly straightforward. I know some of the joint coupling can get somewhat complicated. Of course, feel free to reach out to me or the OKA for this slide deck, and we'd be more than happy to send it to you if you'd like to review after the fact. Okay, moving on here to our foot, or our forefoot rather. Just very, very briefly here, we're going to look at the movements of our first metaphalangeal joint, or first MPJ for short. Of course, as it relates to walking, specifically propulsion and toe off, we're really just concerned with the dorsiflexion of this joint. What we want to appreciate, though, is that the dorsiflexion of this joint does have 3 subphases of movement, as you can see on the slide here. The joint slides, which is completely passive. It's just literally your body weight shifting forward, your center of mass shifting forward over top of your foot, and that's going to promote the sliding of the joint, and that's going to happen between 0 and 20 degrees. The gliding phase, which is next, that's going to happen anywhere between 10 to 50 degrees. Okay, and this is the active phase of first MPJ dorsiflexion, and is absolutely critical for us to be able to effectively get over top of our big toe. Okay, I say it's active because there's very important muscular contractions that are going to aid in this gliding phase. Okay, without getting too complicated, the main muscle involved in that gliding phase is actually going to be our peroneus longus, Our peroneus longus is going to, of course, run down the lateral side of the shin, down behind the lateral malleoli, underneath our cuboid, over towards what's called our first ray here, the joint that's made up by our first metatarsal and our medial cuneiform. Okay, our peroneus longus is going to plantar flex our first ray, and that allows our joint to glide, our big toe to glide, so that we can achieve a more optimal dorsiflexion. So if you see someone who's walking with their toes out, if they're not getting that high gear push off, if it's that low gear push off that we mentioned, you can appreciate some dysfunction through that peroneus longus. And again, it's not going to be plantar flexing that first ray. So something to look at from a muscular perspective with regards to training that proper function. And then lastly, the joint actually jams. Okay, and that should happen at 50 degrees and beyond. And that jamming sounds bad. It's not. It's really just stability. The joint is jamming for stability. The key here is, though, if that joint does not glide, if our peroneus longus doesn't pull the head of that first metatarsal out of the way, then we're going to jam before 50 degrees. And that's where we get into arthritic changes in that first MPJ, what we would call hallux limitus, or just pain in that joint. So again, appreciating the complexities of that first MPJ and the importance of getting over that big toe during that toe off or propulsive phase of gait. We'll talk about that a little bit more momentarily when we go into our assessments. So just very, very quickly, we're not going to spend a lot of time on anatomy. This is something we dive into quite heavily in our full seminars. But with regards to the subtalar joint, I just want you to appreciate the main muscles that are going to help stabilize or control our subtalar joint. And those are these. Pretty easy to remember. Okay, again, these are not all of the muscles that evert or all of the muscles that invert. These are the main extrinsic muscles of the foot and ankle that are going to, again, stabilize our subtalar joint. I already mentioned the post tib, strongest, most powerful supinator of the foot. Very, very important for our ability to achieve that rigid lever at push off. Okay. And then again, the rest of those tissues, like I said, we dive into function, eccentric actions, concentric actions, and talk a little bit about just different correctives that you can do, whether it be mobility work or strengthening for those tissues. All right, moving on here. So this is where we're going to dive into our assessment techniques. As I mentioned, these are three very, very quick, simple techniques that you can use if you're not familiar with assessing the foot. Again, our main focus here is on the rear foot. The rear foot, as I mentioned, our subtalar joint specifically, that is our foundation. So again, when we talk about walking is the most functional movement that we do on a day-to-day basis. Okay, we need to understand how to assess the subtalar joint and then correct the subtalar joint if necessary. So our first assessment here, now appreciate the pictures on the screen here. Camera angles typically are never perfect. I do always recommend assessing in person whenever possible. But just to go over the details of this part of the assessment, this is where we're assessing someone's relaxed calcaneal position. This can be really helpful to understand when you're working with someone who has to stand basically in one place for maybe 8 to 10 hours a day. So think of, maybe a bank teller who stands, someone works in a factory on a line, all these different jobs that require just static standing positions. This can be very helpful to understand in order to appreciate, okay, do I need to maybe refer this person to get an orthotic to help them offload their tissue while they're standing for long periods of time? Or can we use corrective exercise techniques to help stabilize their arch and then just give them a more efficient, relaxed stance position? So what we're looking here, you can see the left and right sides are separate. Again, relaxed calcaneal position. What we're assessing essentially is the angle of the Achilles tendon. So on both sides here, it's probably a little bit more obvious on the left side. You can see there's a curvature, there's a bowing or an inward bowing of that left Achilles tendon. Hopefully you can appreciate the line I've drawn on the screen there. And then same thing on the right. It might be a little bit more subtle on the right side here, but I would say that the Achilles is bowing inwards on both sides. That is representative of subtalar joint eversion. Remember that medial tilt of the calcaneus is going to be representative of that subtalar joint eversion position. Now, when we're standing just in that relaxed position, ideally, we want to be neutral. So this person could definitely benefit from arch strengthening because they're on 2 feet at one time. Our main focus would be on the intrinsics of the foot. Okay, so again, we see a little bit of subtalar joint eversion on both sides. Then moving on to our second test here. So this is going to be an active calcaneal position. Okay, and again, this is essentially a continuation of our step 1. So as soon as we go into a single leg position, what proximal muscle should kick in? That's our gluteus medius, right? That's our single leg stability. That's our pelvic stability muscle when we're in that single leg position. So again, you can think of this like our mid stance position during the gait cycle. This is where we need balance. This is where we need pelvic stability. This is where we need foot stability. Now, during this test, the test is not a balance test per se. If you want to do a balance test, of course, you could do that separately. But typically, I always give my patients something to hold on to, whether it's a wall, a squat rack, or a stick to hold on to. So let's take balance out of the equation and just see how their joints respond to being on one leg. Okay, so again, we're testing activation of the gluteus medius and what that does to our foot. Of course, when you're doing a thorough assessment, you can also appreciate the pelvic position and is there any shifting in the pelvis as they go onto one leg. Now, if we go back up a slide here, let's start by looking at the left side. So we've got the left side, there's that curvature in the Achilles tendon, it's bowing inwards. And then if we go to the active calcaneal position, you can see the same thing. It's still bowing inwards. So what should happen, what would be ideal, is if we went from that bowing inwards here and then to a single leg position, our left glute med would kick on to provide us with that pelvic stability. And that pelvic stability is going to help drive femoral and tibial external rotation. And if you remember our joint coupling, tibial external rotation is coupled with subtalar joint inversion. So what we would see in a perfect world scenario would, of course, well, this would be neutral in a perfect world scenario, but we would see this slight curvature in the double leg stance become completely straight and neutral in a single leg stance. So that's the ideal. So when I see this, I think, okay, this person needs more pelvic stability, more glute activation in that single leg position, which is going to help drive stability through the foot when they're on one leg. Of course, you can work on tying in the foot with the pelvis and the glute med. In our courses, we teach something called foot to core sequencing. And again, it's just full integration of the foot with the pelvis and our deep core musculature. Okay, now we can compare that to the right side. Again, I would say there's still that slight curvature on the right here, bowing inwards a little bit. And then if we go down, it does look like it's quite a bit more straight. So again, I would argue that in this position, she's getting right side glute med activation, but not left glute med activation, as we've seen a little bit of a correction. I'd probably like to see a little bit more. There looks like there's a little bit of a curvature towards the top, but the Achilles appears to have neutralized, meaning that the subtalar joint is in more of a neutral position. Okay, so again, we've gone from our relaxed calcaneal position test to our active calcaneal position test. One other thing to note here, especially when you're doing the double leg stance, the relaxed calcaneal position, have your patients line up with their feet pointed directly forward. Now, again, a lot of people stand with their toes pointed out. We already talked about that. But for this test, it's very important to get an accurate view of the Achilles. You need your patients to bring their feet in, have their toes lined up, pointed directly forward. I'll often kind of help guide them to what is the position they need to be in. And then I'll step back and quite literally get down on the floor to get the best view of that Achilles tendon that I can get. Okay, so again, toes pointed forward in that double leg and single leg stance test. So that's relaxed. This is active. And then lastly, but certainly not least, I have often said, if you got a patient and you had time for one quick assessment, this would be it. Because this gives you a lot of information about the efficiency of their push-off. Okay, so again, this is our active rigid lever position. This is essentially, again, testing the propulsive phase of gait, testing that toe-off position. So a few things we want to make note of here. Number one, we want to see inversion. Why? Because inversion is locked, stable, and rigid. We need to be stable as we push off the ground. That's what allows for that catapult effect, that efficiency. Okay. So if we look at, again, we'll go to the left side here first, which actually looks quite good. So if we go back up to compare, so single leg position, you can see the line bows inward. So that person is in a subtalar joint everted position. If we go down to the next slide here, the active rigid lever position, we can see the opposite. That line is now bowing outward, which is representative of subtalar joint inversion. And you can see it a little bit better with the heel here. So that is a lateral tilt of the calcaneus, subtalar joint inversion. That is a much more locked, stable, and rigid position. The other thing that we want to notice is the position of the metatarsal head. So you can see hopefully that white line drawn across the met heads. Can you see how that line is perfectly horizontal? Okay, that is representing how we want to push off the ground and even force distribution through our metatarsal heads. Okay, if we compare that to the right side, we can see that there's a little bit of bowing outwards of the Achilles tendon here. So it's a little bit better, a little bit more subtalar joint inversion, again, compared to what we were seeing here. So it's somewhat neutral here. And then here we can see, again, that slight inverted position, that tilt laterally of the calcaneus. But if you can note here, hopefully you can see that line is not perfectly horizontal. So it's kind of angled towards the outside of the body, which essentially means that individual is pushing off more through metatarsals 3, 4, and 5 instead of directly going over that big toe. Now, to understand why they're doing that, we would have to, dig deeper. We'd have to look at the range of motion in their big toe, potentially a few other things. Again, these are all assessments that we teach in our full courses. We would teach like a navicular drop assessment, which is going to give you some good information about the control in their arch as well. But here, again, we want to appreciate that this left side is basically spot on, horizontal across the met heads, so even force distribution, while that subtalar joint is in a locked, rigid, and stable position. Again, comparing that to the right side, there's a little bit of that inversion, but that person is avoiding their big toe. So if they push off the ground like this, which they would, because if they do it in a single leg stance test like this, they're definitely going to do it when they walk. That person is essentially avoiding their big toe. So again, we would classify that as a low gear push off. It's much more inefficient than what we're seeing on the left side. And of course, I always make the argument that, let's say what we talked about earlier, 5 degrees of ankle joint motion is the minimum. Let's say 10 is ideal. Okay, I might never get my patients to that ideal range of motion, but when it comes to walking, we want to be as symmetrical as possible. So definitely with this individual we see on the screen, I'd be working on getting directly up over top of that big toe. And as I mentioned, assessing a little bit further. Why isn't that person getting over the big toe? Does it have something to do with what we talked about with regards to first MPJ range of motion, that gliding, that active phase of first MPJ dorsiflexion? Is the peroneus longus pulling that first ray out of the way so that individual can get over top of their big toe? Okay, so again, 3 very quick assessments that you can do with your patients. Hopefully that makes sense. Again, please reach out if you have any questions. And then if you'd like to, of course, dig deeper with this content, definitely check out one of our full courses. Okay, and just to finish off this evening, like I said, we're not going to have time to get into the nitty-gritty, but just briefly looking at some correctives for an oversupinated foot or an overpronated foot. Okay, so we'll start with oversupinated. Okay, as I mentioned earlier, this foot type that you see on the screen, when that foot hits the ground, it's like a cinder block hitting concrete. There is no shock absorption. There's no adaptation to the ground. So our goal with that individual is going to be to try and mobilize specifically their foot. But we have to appreciate that when a person is rigid at their feet, that rigidity often gets transferred up the system. So that person could lack dorsiflexion, lack shock absorption through their arch. They could lack hip extension, thoracic rotation. So those are all things to be aware of when you see an oversupinated foot, and appreciate the goal with that individual is going to be mobility. Okay. Specifically, as I mentioned, at the foot, intrinsics of the foot, we want to loosen up that arch. We want to look at the extrinsic muscles that are holding that foot in the inverted position. So that's our post-tib, our tibialis anterior, and then of course our soleus as well. And then, as I mentioned, you can work up into the pelvis, the thoracic spine. With regards to release of the bottom of the foot, just in terms of home programming for my patients, this is stuff that I do with them or I have them try to do on a daily basis. We'll take any sort of a small ball, like a golf ball, for example, and I'll have them release several parts of the plantar foot. So first and foremost, we're going to go right behind the big toe there. There's going to be several muscles that run along there. You've got your flexor hallucis brevis, flexor hallucis longus, your abductor hallucis, lots of tissue in that medial arch that we want to release. We're going to come then down just underneath the cuboid. So we're just in front of the calcaneus. That's going to be where tissue like our peroneus longus tendon is running under. And then also we just want to really get that arch to adapt to the ball that it's on. And again, this can be done in standing or seated, depending on the person's tolerance. But releasing and applying pressure to that cuboid is going to allow for more arch adaptation. Okay. And then lastly, what I would do is I'd take that small ball, I'd probably put it right behind metatarsals 2 and 3, and then just have them apply that pressure. That's going to, again, allow for what we've talked about earlier, those metatarsals to display, to open up as they push off the ground. So those are 3 quick and easy areas in the foot that you can release to allow for better adaptation in a foot like you see on the screen. Okay. And then lastly, with regards to overpronation, our main goal is going to be to increase stability. Okay, so of course there might be some mobility work that we would want to do. We would want to, maybe look at the everters of the foot, the gastroc, specifically the lateral gastroc, the peroneals, specifically the brevis. We want to look at those tissues, see if we need to do some mobility work there, and then it's going to be strengthen, strengthen, strengthen. So we want to activate the intrinsics of the foot. Look at that post tib, test the post tib strength. Okay, we need to get that most powerful supinator of the foot strong, active, and functioning better. And then, as I mentioned in our full courses, we teach that sort of foot to core connection, which is going to be very, very important. There's a lot of connections, both fascially and neurologically, from your foot to your pelvic floor. Okay, your pelvic floor, obviously the foundation to our core. You want to talk spinal stability. You can't do that without talking about your pelvic floor. And that's very, very much connected with our foot, as I mentioned, both fascially and neurologically. So we need to be able to, again, focus on stability with these types of patients. Okay. And I just saw that question pop up, which we'll answer momentarily with regards to the course website. So our full course here with regards to the continuation of this content. So our barefoot training specialist course, our next one is actually coming up very, very quickly here. It'll be on November 4th and 5th. If you are a part of this webinar, you can reach out to me and you will get a fantastic discount. So definitely reach out if you're interested in that. Basically, the content consists of understanding the sensory importance of the foot, a lot of expansion on the biomechanics, which we dove into today, the anatomy as well. We talk about footwear, lots of great content. And then I also mentioned the foot to core sequencing and corrective exercise techniques, much more specific than we had time to dive into today. So again, with any of questions that you may have, feel free to reach out. In terms of contacting me, you're welcome to follow me on like Instagram. So I'm barefoot_Canada, Barefoot Training Specialist Canada on Facebook. Our website is ebfaglobal.com. The course that I mentioned is going to be live online, but we do have a pre-recorded online version. I typically recommend the live version because then it's much easier to ask questions, get feedback, and you have much easier access to me if that's what you would like. And then, of course, we also do in-person courses as well. And again, if you're someone who owns a clinic and would like to host a course for yourself, for other therapists, again, feel free to reach out as well. But that wraps up the seminar from my perspective. If there are any other questions, feel free to shoot them my way. Again, big thanks to the OKA for allowing me to do this, and I hope it was beneficial for all of you.
Thank you so much, Stuart, for this presentation.
Of course, yeah, my pleasure.
Awesome. So if there are any questions right now, we can send them our way to OKA, and we will make sure that you guys get answers as we are at our time. And I don't want to keep anybody too long tonight. But if there are any questions, feel free to email Stuart directly or to email us here at OKA. In regards to this presentation, we will be posting it on Keen later on once everything is processed. And you can always also email us to get a copy of this presentation as well. Once again, I'd like to say a big shout out. Thank you so much, Stuart, for doing this presentation for us. We really appreciate all the time you take, and thank you all for joining us. And until the next time, have a great evening. Good night, everyone.